The main reason why I started is because of the back pain of patients after surgery. I started to go in minimal invasive techniques like the matrix, MTD, and then I shifted to the endoscopy, and that's something what I really liked. I did the MTD as well, but it didn't improve the back pain of the patient after surgery.
Between the open spinal surgery and endoscopic spinal surgery, the difference is too much.
There are many solid evidence that support that endoscopic spine surgery having good outcome, better results, and less complication.
There is a less scar tissue and less infection, whereas the efficiency of the surgery is the same as open surgery.
The reason why I like the transforaminal part is just because all the pain generators are there. The facet joint, the posterior ligament, the dorsal root ganglion, and the disc material itself. The most wonderful part of the system is that the drills, they are so fine to use for neuronal structures that I know that if the tip of the drill is entering the spinal canal, nothing is happening.
They're sharp enough to drill the bone, but they have a blunt tip. And this is definitely important if, let's say, you're doing foraminotomies. So if the goal of the surgery is to enlarge the foramen, not necessarily to take the disc out, but if you have foraminal stenosis, then this definitely comes in the first place.
Where you can cut through the facet joint and without harming the dura or the nerve root. And once you pass the facet joint, and I try to always perform a foraminoplasty. Once you pass the facet joint, you have to beware not to damage neuronal structures, but therefore the patient is awake. And once you only touch the nerve, the patient will tell you, "Ooh, I'm feeling leg pain." And then just change direction, and that's it. If you come from the transforaminal part, the first thing you see, if you are close to the PLL, is a disc herniation. Once you remove the disc herniation, the nerve root will come down if you are operating in a prone position. So we don't have to touch the nerve root at all. So it's really safe surgery in my opinion. For some cases, I think it's better to do the interlaminar approach. For example, if the disc herniation is in the axilla and the nerve root is pushed in the lateral recess, it's dangerous to go from the transforaminal approach, and then you can go interlaminar. And of course, if the window of the interlaminar space is really wide, it's also easy to go interlaminar. More easy, I think, than to go from the transforaminal part, especially for people who are starting with transforaminal surgery. The initial reason why I work with MaxMore is because I was taught the technique by Tom Hoogland.
Training the surgeons is actually our main work. Most of our time goes into organizing courses, sending surgeons to other surgeons.
We have a nice program. We do a beginning, a middle and an end. They come here for training. Then they go to our faculties to watch them. And then when they have the first cases, we organize for the faculty to go to them and assist.
If he sees a live case with a colleague, he can estimate, okay, this is something I want to do in my practice. I want to put my time into it and I want to make a plan. And then they should come to us and we make a plan together.
So many attendees who finished the cadaver course came to our hospital, see the way on live patients, how we treat them, how we operate them, and then some of them asked us to go to their hospitals and to continue their education. And I think when you have all the three steps of it, then you can have a safe, well-trained surgeon in endoscopy.
Then you can start on your own, but make sure that you have a backup surgeon close to you if you have troubles.
It wasn't once that participants after this kind of courses who took my phone number or email address contacted me and asked me suggestions how to proceed, what to do. So, and as I told you, some of them even called me to come to their hospital and to help them. And this is why this kind of program is appreciated from both sides, me as a faculty and them even more maybe as attendees.
We don't teach the doctors of the future what the future is. How will we progress?
They are trying to advance the courses and they are ready to send you to anywhere you want if it will be of benefit to you to go and see any doctor that can train you.
I sent 2 doctors from Bosnia to Dr. Welchli in Switzerland, and they were completely amazed. They loved it. They saw everything from endoscopic to microscopic, everything.
It's easy to access to the staff, not only staff. You can access to the COO directly if you face any problem during the installation of the sets, or even help you to recommend many consultant and expert opinion.
When you send for repair, they immediately answer you. They can replace it or repair for you.
Not only the theater, but all my fellows, they always pushing me to do the endoscopic spine surgery because they think that's the outcome is better. And you know, they are enjoying in the theater, so no loss of blood, no comorbidities, and even no any less complication compared with the open surgery.
We have shown that in our study it's comparable to the open microdiscectomy, around 5% within 1 year. And the patients do recover really fast, faster than open surgery. There's less blood loss, less complications. And the patients likes the operation. They don't get general anesthesia, no tubes whatsoever. And the cost effectiveness is better in the endoscopic discectomy.
Endoscopy is growing. So there's more interest from surgeons in general. There are basically 3 kind of reasons why we grow. One is the product line, second is the market or different countries, and third is the volume of surgeons that want to do endoscopy.
Scientific data are growing each day more and more, and there are cons and pros for each technique, but endoscopy is definitely getting there and growing more and more each day.
I think there is evidence now, enough evidence that it's at least as good as open surgery, but I think on the long term the endoscopic surgery, also from societal perspective, will have more benefit not only for the patient but also for the society as a whole.
The same efficiency as open surgery, but with less possible complications.
Less infection, less bleeding, and then the patients are more satisfied. They leave the hospital the same day or the next day, maximum.
The patient comes in and goes home the same day. It's like that great. So it's a surgery for the people. It's not a surgery for the clinic, it's a surgery for the people.
I think that's the way to go in the future.
Just to give the best to the patients. And I think with endoscopic spinal surgery, the best is here.